So hello everyone, welcome to the channel GDC English. In this video, we do have another set of general pharmacology MCQs, particularly of pharmacodynamics. Right? So let's get started without wasting any time. We should have our first question, that is the substance binding to one receptor subtype as an agonist and to another as an antagonist. It is called as partial agonist, non-competitive antagonist, competitive antagonist, or agonist antagonist. So it has been asked previously also that agonist antagonist is a type of substance which binds to one receptor as an agonist and the another one as an antagonist. All right. For example, if we talk about the pentazocine, the pentazocine, it is an kappa opioid receptor agonist. All right. But mu opioid receptor antagonist. It is one of the example of agonist and antagonist. All right. So the answer is agonist and antagonist. So rate of absorption of drug by passive diffusion is maximum in. Okay. Is it small intestine? Is it large intestine? Is it stomach or it is esophagus? Absorption. See, there is no absorption in esophagus. There really no any kind of absorption in the esophagus. Small intestine? Yes. Small intestine having the highest rate of absorption of drug by passive diffusion because small intestine presents microvilli. Microvilli. These microvilli increases the surface area. Increases the surface area. Right? So it will increases the passive diffusion, that is rate of absorption. Okay. So it's now your turn, guys. That what kind of order does passive diffusion follows? Which order does passive diffusion follow? You have to write into the comment section. All right. Sure. Small intestine would be the right answer. All right. Chalo, chalo, chalo. About acidic drugs, true statement is asking better absorbed in the acidic medium, better absorbed in the alkaline medium, not absorbed in the acidic medium, or binds to alpha glycoprotein. See, always whenever the acidic drug, let's talk about the concept first. The drug has to be absorbed, it has to be in its the unionized form. It has to be in its unionized form, isn't it? Unionized form. And then, which kind of drug will be in the unionized form? Whenever the drug, for example, a drug is having of weakly acidic in nature, and that drug is getting the same medium, that is the acidic medium. Weakly acidic. This combination will be the unionized one. The drug will be into the unionized state, which will increase its lipid solubility, because it is one of the reasons for better absorbability of a compound. Increase the lipid solubility, increase will be the absorption. So acidic drug will be absorbed into the acidic medium, that is in stomach. All right, that is into the stomach, which has a pH of 1 to 3. That is 1 to 3. Okay. Weakly basic drugs absorbed from the alkaline medium, that is into the small intestine. Not absorbed, there has a no value of this statement. Binds to alpha acid glycoprotein. See, these are the proteins, binding proteins. These are the binding proteins, and the HSA, that is human serum albumin, HSA, that is human serum albumin, binds to the acidic drug. Binds to the acidic drug, not to the basic drug. Basic drugs binds to this alpha acid glycoprotein. All right. So your right option will be this one, better absorbed into the acidic medium. All right. Yes. Chalo. Bioavailability. What is bioavailability? The fraction of the drug. Bioavailability says that fraction of the drug. Fraction means the percentage. Fraction of drug reaches into the systemic circulation without changing its form. All right. So what is the formula of it? AUC oral by IV? No. AUC IV by oral? No. AUC oral by AUC IV into 100? Yes. This is the correct option of the formula of bioavailability. But what is AUC over here? It is the area under curve. Everyone knows it. But what does it signify? What does AUC signifies? It signifies the extent of absorption. Extent of absorption. Right? AUC means the extent of absorption. AUC oral divided by AUC IV into 100. Why IV is in the dominant denominator? Because AUC IV gives you the 100% bioavailability. That is the standard one. It is considered to be as the standard because the bioavailability of the IV is 100%. Okay. So option will be C is the right one. Yes. Which of the following is not the factor of affecting volume of distribution? Okay. Volume of distribution. Not the factor. Okay. Lipid solubility. Increases the lipid solubility. Increase will be the volume of distribution. Right. Plasma protein binding. Increase the plasma protein binding. Less will be the volume of distribution. Right. Ionization. Yes. If it is ionization, there will be less volume of distribution. Presence of food. Yes, presence of food doesn't have any correlation with the volume of distribution. Lipid solubility directly proportional to the volume of distribution. Plasma protein binding inversely proportional to volume of distribution. Ionization is inversely proportional to volume of distribution, whereas presence of food doesn't have any correlation between the volume of distribution. All right. Yes. So right option will be the presence of food. Yes. Which among the following is not the high plasma protein bound drug? Which among the following is not the high plasma protein bound drug? That is NSAIDs, phenytoin, lithium, warfarin. So answer is the lithium. Why? Because it is the one of the narrow therapeutic index drug. It have the narrow therapeutic drug index. It has the shorter pharmacokinetics profile. That's why it does not have the high plasma protein binding. Okay, all right. Yes, so lithium will be the right option. Yes, lithium. Okay, sure. What does low volume of distribution of drug mean? What does low volume of distribution of a drug mean? Low bioavailability, dose does not accumulate in the tissues, low absorption, or not metabolized into the body. See, higher the volume of distribution, higher the drug penetrates into the tissues. Lower the volume of distribution, lower will be the penetration. That means there will be a no accumulation, does not accumulation into the tissue. That is B point. B point would be your right. Right? Shall. Yes. Drugs which are highly bound to alpha acid glycoprotein are of the followings. I've just told you that alpha acid glycoprotein binds to the basic drugs, isn't it? Binds to the basic drugs. So, out of which are the basic ones? The imipramine, quinidine, which have the amine, isn't it? Amine group. That one are the basic drugs in nature. So, beta blockers, imipramine, quinidine are the basic drugs, whereas the barbiturates, these are the acid-rich drugs, bind will bind onto the HSA, that is human serum albumin. So answer is the beta blockers, imipramine, quinidine is going to bound to the alpha 1 acid glycoprotein. Yes, yes. Chalo. So the binding order of drug to tissue is that, yeah, this one is very much important to you guys. Very important. Directly is been asked. It has been asked directly. So binding of the drug towards the tissue. So the liver is the very much prone to bind the drug because of the metabolism part, isn't it? Then afterwards there is a kidney. Then afterwards there is a lungs, and then afterward there will be the muscles. Right? So C one is very much right. Okay. Chalo. Which of the following is the primary site of drug metabolism? Just told you. I've just told you that the primary site of the drug for metabolism is nothing about the liver. Alright? Chalo. Next. Liver. What is the active metabolite of codeine? What is the active metabolite of codeine, which is an opioid drug and have the morphine? Morphine, oxazepam, diazepam, phenobarbital, and morphine. So the codeine will be the prodrug, and active metabolite is morphine. All right. Yes. Chalo. Yes. Morphine. Okay. Chalo. What is the prodrug of dopamine? Dopamine. What is the prodrug of dopamine? Carbidopa? No. Levodopa? Yes. Levodopa is the prodrug of the dopamine. Next, dopamine. Eliminations after 4 half-lives in first order kinetics. First order kinetics. So, in first order kinetic, there will be a same fraction of drug eliminated. Same fraction of drug eliminated. Isn't it? Same fraction of drug is eliminated into the first order kinetics. If we talk about the zero order, then there is a constant amount of drug. For example, 20 mg of drug is eliminated per hour. That is the constant amount. But if we talk about the first order, then the same fraction, that is the percentage. Percentage. Okay. So 4 half lives. So let have the if the drug is having the 100%, after the first half life, the drug will be the 50%, isn't it? 50%. Second half life, then half of 50, that is 25%. But you have to add it. You have to add it. That is 75%. And then 12.5, that is 87, isn't it? Then 6.25, it will be around the 93%. It will be around the 93%. So you will be the answer would be 93%. All right, 93% will be the drug eliminated after 4 half life. Right? Shall yes. Pharmacodynamics involves the study of what? drug, D for drug, does to the body. So it do includes which of the things? Mechanism of the drug action. Very much simple. The mechanism of drug action will be involved into the pharmacodynamics. Rest of the things, that is biotransformation, which is itself a metabolism, distribution, excretion, absorption, that is a part of the kinetics. That is the part of kinetics. All right. Yes. So answer will be the mechanism of drug action. Okay. So yes, a non-competitive inhibitor of an enzyme will do what? What was happening there? That a non-competitive inhibitor was acting onto the substrate as well and acting onto the enzyme substrate complex as well, isn't it? So this is the inhibitor, and this was leading to the decrease in Vmax, but constant Km. What was Vmax decreasing was signifying that there is a decrease in the enzyme activity. Decrease enzyme activity. So there will be a decrease Vmax because the inhibitory drug is binding onto the substrate as well. Substrate as well. Not to the binding onto substrate, but it is competitively, it is in the competition with substrate. All right, onto the free enzyme, and it will bind onto the allosteric site. Bind onto the allosteric site. Also, it will bind onto the enzyme substrate complex, which ultimately decrease the Vmax of the enzyme. That is, decrease the enzymatic activity. All right. Yes. Chalo. Okay. What does term bioavailability means? What does term bioavailability means? Plasma protein binding, degree of substance? No. Permeability through the brain blood-brain barrier? No. Fraction. I've just told you that fraction of an unchanged drug reaching the systemic circulation following any route of administration. For example, you have taken the drug through orally and it goes into the systemic circulation. You have got the drug into the systemic circulation in the unchanged form. That fraction, for example, you have taken the 100 units of a drug, but only after the absorption, only 70 units is being found onto the your plasma. Then what is the bioavailability of the drug? That is the 70%. That is the 70%. All right. This might be the decrease in the bioavailability might be due to the first pass metabolism also, isn't it? So the fraction of unchanged drug reaching into the systemic circulation following any route of administration, that is the bioavailability. All right. Yes. Chalo. Okay. Which of the following is a phase 2 biotransformation reaction? Which of the following is a phase 2 biotransformation reaction? Sulfoxide formation, nitrodeduction, ester hydrolysis, or the sulfate conjugation. So everyone knows that the all type of conjugation reaction comes under the phase 2 biotransformation reactions. All right. So the sulfate conjugation is one of the type of phase 2 biotransformation reaction. Getting it? Yes. Sulfate conjugation. Okay. The fastest acting receptor is ligand gated ion channel, GPRS, enzymatic receptor, or nuclear receptor. What is it? So the fastest acting receptor is the ligand gated ion channel, and it shows the effects in milliseconds. Milliseconds. And which is the slowest one? The slowest one is the nuclear receptor, the slowest. And which one is the most abundant? That is the GPCR, that is most abundant. All right. Sure. Ligand-gated ion channels. Pharmacodynamics tolerance may involve changes in number of the receptor, affinity of the receptor, function of the receptor, or all of the following, or the all of the above. So the answer is all of the above. That is numbers, affinity, and functions. All the things changes in the drug receptors. All right. So all of the above. Yes. G protein couple receptors present on the plasma membrane has a bundle of how many helix? Because G protein couple receptor is also known as the heptahelical. That is why this hepta signifies the 7. Hepta signifies the 7. Alright. So GPCR have the 7 bundles of alpha helix. For example, this over here. First, 2, 3, 4, 5, 6, and 7. First, 2, 3, 4, 5, 6, and 7. Alright. This is the structure of GPCR receptor, G protein couple receptor. But what is G over here? Can you guys tell me what is G over here? G stands for which one? G stands for the guanine. It is already asked in your exam that guanine is G protein coupled receptor. Alright, so this is all about the questions we have for you in general pharmacology, that is particularly from pharmacodynamics part. So I hope I have made you clear about these topics, about these concepts. Till then, keep grinding yourself and keep preparing yourself. Thank you so much.